diagnosis and multidisciplinary management begin with precise imaging, which plays an important role for the guiding clinical and surgical decisions. It is my pleasure to introduce our speaker for today, Dr. Anu Gayatri Jawahar. She is head of the abdominal imaging in Northwestern University, Chicago, USA. And she is co-director for abdominal imaging, medical student radiology executive, then associate program director for diagnostic radiology residency program. Welcome, Dr. Anu Gayatri.
Thank you, sir. Thank you.
She will be highly giving us all the aspects of the pelvic floor imaging based on the MRI. And for today's session, she will take us through anatomy, imaging protocols, interpretation, and clinical relevance of pelvic floor imaging with practical insights that are directly applicable for day-to-day practice. To moderate this session, we'll be having Dr. Antonio, Consultant General Surgeon from Burjil Daycare, Kahama, and Dr. Nasreen, Consultant General Surgeon, Burjil Medical City. Thank you, Dr. Antonio, and thank you, Dr. Nasreen, for joining.
Thank you for the invitation.
Dr. Yasir will be coordinating this session. Dr. Yasir is head of the department, Burjil Hospital, Abu Dhabi. And I just wanted to mention one more point. For availing the DOH CME points, everybody will have to submit the evaluation form at the end of the session. And definitely, we are confident this session will be highly informative and valuable for all the radiologists, clinicians, surgeons, and we have few rehab clinicians and rehab therapists as well in today's webinar. It will be helpful for them as well. Thank you everyone for joining. Over to you, Dr. Anu Gayatri.
Yeah, thank you so much for the invitation, sir, and thank you, Dr. Jayesh, for giving me this opportunity. I'm going to share my screen. Can you see my screen?
Yes, doctor.
Okay. So we're going to talk today about like when, why, and how questions on the MR pelvic floor, and I have some cases to review. I do not have any disclosures. Quick review of like overview of what my presentation is going to cover is pelvic floor anatomy, how to read a pelvic floor MR, and some review of cases. For the background, why we place importance on like pelvic floor imaging is because they are highly prevalent disorders, though they are underreported or undermined by the patients themselves. It decreases the quality of life. Patients can have incontinence, pelvic pain, sexual dysfunction, and it's more prevalent in the elderly and female population, especially following trauma from labor. It increases with age, like over 50% of the females over 80 years have pelvic floor dysfunction of varying degrees, and the probability of having surgery is about 1 in 5. It increases with parity, like 12% of patients in nullivers as compared to 32% in females who have more than 3 deliveries. And it increases in patients with obesity, 15.1% in patients in normal weight, as opposed to 30.4%. It's like double the rate. And the cost of implication with the surgery also like causes a more impact on the insurance and health costs. So going over some clinical implications and imaging options, what's available for pelvic floor evaluation. So the common indications that we get for pelvic floor in radiology department is pelvic dyssynergia, constipation, excessive straining, having a bowel movements, requiring a digital evacuation, low back pain, or even pelvic floor pain. So why clinical examination is not sufficient and why radiology plays an important role is because clinical examination can underestimate the problem because they do not do like with straining. It's hard to evaluate, especially the posterior compartment. It can misdiagnose a type of prolapse between a middle compartment versus posterior compartment, depending on whether the vaginal wall or the rectal wall prolapse is present. They can misdiagnose the compartmental prolapses. It does not evaluate the evacuation disorders, especially the posterior compartment. It cannot detect the peritoneal seal or enteroseal, which is in the middle compartment. And also the most important point is the anterior, middle, and posterior compartments are evaluated by different clinical specialties. For example, the anterior compartment is evaluated by urogynecology, the middle compartment by the gynecologist, and the posterior compartment is by the GI surgeons and the gastroenterologists. So sometimes they assess the pelvic floor disorder and they say one compartmental prolapse, but then there is also existence of the anterior or middle compartment. If they perform surgery or management of one compartment, and patient will get better with that posterior compartment, for example, and then they come back few months later or few years later saying like they have an anterior middle compartment, whereas imaging can evaluate all the three compartments and can reduce the cost of surgery and the time taken for the patient. So dyssynergic defecation evaluation with digital rectal has reported a sensitivity of 75% and a sensitivity of 87%. So there is other exams like POPQ exam, which the gynecologist performed in the clinic, where they have a complex 9-point. I'm not going to go over this because it's much more complex. So they have a 9 points. They perform the patient in standing, and they also ask the patient to like strain, and they can see how the vaginal wall prolapses into the cavity, and they assess the pelvic organ, like the middle compartmental prolapse, and they manage them based on that. So for this, the reference line for them is the hymen. So I'll go over why this is important for us on imaging. For them, this hymen is the reference point for the POPQ. And of course, the POPQ doesn't evaluate the anterior or the posterior compartment. There is also anorectal manometry for the posterior compartment, which kind of evaluates multiple things. They measure the anal sphincter function. Technically, they kind of put in a balloon filled with like water, and they distend the balloon, and depending on how much of pressure it distends, they assess for patient's sensation for evacuation, how much it takes to expel the bulb. All those are kind of evaluated. This is something in most hospitals they do first as a clinical step, and when this is abnormal, they come back to imaging to assess for further evaluation. So those are like clinical evaluation systems. When it comes to our imaging, we have different options. We always offer a flavor of different imaging modalities. We have fluoroscopic difficography, we have MR, and also translabial ultrasound. I'll go over like why each one has its own perks and others. The translabial ultrasound, it evaluates for actually mostly the anterior and the middle compartment, but not to the extent which has precision. So there's a high frequency probe placed on the labia, and this is how the images look. They look for how the organs are prolapsing. They evaluate for urinary incontinence, prolapse, obstructive defecation, but of course they cannot do it with stress with the organs, especially with the higher grades of prolapse. It's going to be hard because you're having a pressure over the pelvic floor. You cannot assess for the bulge of the organs through the pelvic floor. It has a very limited field of view. And as I said, like having the probe at the pelvic floor or the translabial position limits the evaluation for higher degrees of prolapse. Fluoroscopic difficography, this is how a setup occurs. We do not have in our hospital because of the logistic difficulties. Patients are more uncomfortable with the fluoroscopic difficography than an MR one, because patient has a modified, it's a customized chair, and patient sits on this kind of a commode, and then with the gel that's put in the patients, they have to evacuate through it. And this place is open, so patients find it very uncomfortable doing an evacuation maneuver in front of everyone who's watching from behind the LED screen. So that's one. And also patient has a lot of radiation exposure with this examination compared to MR, where we do not have any radiation. The other big point is like the anterior middle compartments are not evaluated. It's only for the posterior compartments. For example, I want to show like comparison of how a fluoroscopic difficography and an MR evaluates on the same patient. This is a 68-year-old patient with rectal pain, and on top we see the fluoroscopic difficography. And then you can see like this contrast in the rectum. You can see the femur for the anatomy, and then you can see the coccyx if it's projecting well. These are the landmarks that we kind of like assess. And then you can see when the patient is doing an evacuation, you have an anterior rectocele, and then some amount of intussusception. Whereas with an MR, you can see patient also has a bladder. This is the pubococcygeal line, which is the reference line that we use, which I'll go over in the future slides how to interpret. So this is the reference line for the pelvic floor on an MR. So anything below this is considered pelvic organ prolapse. And you can see this is the anterior. This is the pubic symphysis, coccyx in the back. So this is the anterior part. So this is the bladder. You can see there is bladder prolapse. And then you can see there's an intersusception that we see, and then there's an anterior rectal seal. So you can see there, and then this is the peritoneal seal. This is the peritoneal fat that's kind of prolapsing below the pubococcygeal line, which we shouldn't usually see. So you can see there are multiple anterior, middle compartment, and the posterior compartment for prolapse, which if we do only fluoroscopic evaluation, we will not be able to assess. Is there a role for CT in pelvic floor imaging? Not when it's in its earlier stage, but we can definitely look at these imaging. We do find a lot of pelvic floor prolapses on CT, especially patients who had pelvic floor surgeries, not any pelvic surgery, like gynecological surgery, like hysterectomy, cystectomy, all prostatectomy. All those patients can have like some grades of pelvic organ prolapse. So we do pay attention, and if we see any amount of bladder that's below, or if we see like the uterus or the vagina or the peritoneum below it, we do report on CT. So this is like an incidental. This is like at least grade 2 of the bladder. But if we see them, we automatically refer them for an MR, because this is a static image on a CT that we're assessing. So if the patient has grade 2 on static images when they're performing Valsalva maneuver or like the evacuation maneuvers, this is definitely going to be a higher grade. And it's very important for the surgeons to know what grades they have to perform an appropriate surgery. So this is a static image. That's the other limitation of CT. It is only a static image. We're not doing a functional evaluation in these patients. So again, comparing all the three options that we have, apart from like CT is not a dedicated available one for pelvic floor imaging. Over fluoroscopy and translabial, the MR has anatomical and functional evaluation. It has a dynamic evaluation on MR, not the ultrasound or the clinical examination can perform. It has a larger field of view with multi-compartmental assessment, and it's the only imaging modality that can be used for post-op follow-up, because fluoroscopy is not going to be useful in a post-op patient. Again, on the translabial, similar reasons. So MR will be the imaging modality of choice that will be performed in patients with surgery, asking for like, is there a recurrence? Is the mesh intact? All those questions will be answered only with an MR. So MR like kind of trumps for these reasons over the other imaging modalities. How do we perform this examination? Patient preparation is like we ask the patient to be NPO at least 4 hours and try to evacuate before they come to the examination. The reason is we are putting in a rectal gel, which is an ultrasound gel, into the rectum, and we give them a diaper. So when the patient is doing an evacuation, they kind of evacuate the gel into the diaper. But if the patient did not have a bowel prep and has like stool contents in the rectum, that's going to make it very uncomfortable for the patient when they evacuate, because they get soiled, and it takes at least few minutes, like 10-15 minutes after they finish the exam to get out of the scanner, like removing the coil, unplugging them, taking them to the bathroom. So patients find it very uncomfortable. So it's that's the importance why you want to have an NPO or like have the patient evacuate before they come for the procedure. And we want the patient to avoid 1 hour before, unlike other MR pelvic examinations, like if you're doing an ovarian protocol or uterus protocol, we usually ask the patient to void before the exam. But for MR difficography, we ask them to void 1 hour before. We want some amount of urine in the bladder to assess for anterior compartmental prolapse. You can use anywhere between 150 and above rectal gel, not too much because the patients get uncomfortable before we get in. Usually around like 150 or 200 rectal ultrasound gel is injected, and definitely a diaper. So for positioning of the patient in a scanner, patient lies supine, and we give a small little pillow or a wedge under the knees to kind of simulate the natural positioning and as the patient is sitting in a toilet, not as much as the toilet, but at least trying to simulate them. We use a pelvic coil for the scanning. And the most important part of the examination is coaching the patient. So the technologists spend a lot of time with the patients to train them, because if we say Kegel, do Valsalva, patients are not going to understand them. So they have to say like, try to squeeze your abdomen or the pelvic floor as if you're trying to hold the urine when you're feeling the urge. Or then when we say like bear down, they have to say like, try to like have a bowel movement, but you don't open your anal canal. So you're trying to like bear down, but like not open the anal canal. And then we say like evacuate, they have to know like you're opening up the you're kind of expelling the gel into the diaper. So they have to know. The reason is we have had situations when patients, when we say like, can try to squeeze, and then sometimes they expel the gel. And then like you have to like, you can do the examination, but like Kegel is usually a very shorter sequence compared to the evacuation. Kegel, you do about like 8 to 12 seconds. CME sequences, whereas evacuation is about like 90 seconds. So by when you're trying to do a Kegel sequence that is set for 8 to 12 seconds, if the patient evacuates, then your like your gel is gone. So you have to like pull the patient out, like clean up the patients, and then like re-inject the gel. It only increases the time of the procedure. So we try to like coach them really well. And these are like sample sequences. This is actually a very short procedure for the patient throughput in your scanner. It's about like 15 to 20 seconds. If everything is in position from the time the patient enters the MR suite, it takes about like 20 minutes max. Positioning, putting the rectal gel, and performing the examination. These are some of the important sequences. We do like a sagittal T2 in a resting phase. This is like the base sequence based on which like you start making the measurements. We do like a Kegel maneuver. We do like a CME evacuation maneuver. We also have axial T2. I'm going to tell you what we measure in each of them. This is an axial T2 small field of view for the pelvic floor. We do coronal T2 images in resting and Valsalva as well. Kegel, Valsalva, and defecation phases are all in CME images. So we kind of do a fiesta or single shot Fastman echo so that it's faster, so we can kind of capture the CME images. And these sagittal T2, which is the first base sequence, is a dedicated T2 sequence. And the axial and coronals are also static images. Only the dynamic maneuvers are Kegel, Valsalva, and evacuation phases. So in the axial T2 images, this is the protocol. If anyone is interested, I can share like our institutional protocol. So it's just about, I'm talking about like how it's done. So the axial, sagittal, and coronal are done in a resting phase. It's not a dynamic maneuver. And then the field of view is to cover from the rectum to the gluteal folds and like sacrum to the pubic. We're not covering the entire pelvis. The field of view is more to cover until the gluteal folds. In the other MR pelvises, we don't cover all the way to the skin folds. In this, you'll go a little lower so that we are able to see the pelvic organ prolapse if it's going outside of the field of view. And then the dynamic maneuvers are these defecation and Kegel and Valsalva maneuvers. So this is how, these are like GIF images to like show how it appears. This is a resting phase, so you won't see any movement. So in the Kegel, you will see the pelvic floor or the posterior wall of the rectum. You can see that kind of moves up. With the Valsalva, this moves down, and in evacuation, you can see the gel is kind of getting expelled. Comparison between Valsalva and evacuation is the gel never gets expelled. The pelvic floor descends, however, the anal canal is closed, whereas in an evacuation, the pelvic floor descends with the opening of the anal canal. So that's the difference between the Valsalva and the evacuation. So coming to the pelvic floor anatomy, so it has three contiguous layers. It has an endopelvic fascia, pelvic diaphragm, and an urogenital diaphragm. So endopelvic fascia is the superficial layer or the superior layer. It provides passive support, and it's usually not seen on an MRI. The fascia is not usually seen, but we do see indirect signs of when it is defective. So there are three layers of endopelvic fascia. So the level 1, which is colored in pink here, it's covers the vaginal apex to the uterosacral ligaments. And usually this uterosacral ligament, the posterior attachment, is avulsed in 96% of the patients who have parity. And that's another reason why they have a lax pelvic floor, because of the parturition. Level 2, which is colored in blue here, supports the middle third of the vagina and the posterior part of the bladder. And level 3 is the most inferior one, which supports the lower vaginal wall and the perineal membrane here. So how do we see if there is a defect or weakness of the endopelvic fascia? Because the fascia by itself is not seen. If it is defective, in the level 1, which is the superior one, you will see them as chevron sign. For example, this is a normal like vagina that kind of looks like a head-shaped structure. That's the normal appearance it should be seen. Whereas when it is defective, you can see the vaginal canal will be seen in an inverted V shape. Instead of looking head-shaped, it will look like an inverted V shape. That's a sign that the endopelvic fascia is defective. We can see these sometimes even on CT. So when I see it on CT for the bladder also, like I'll show you the bladder, we do report saying like, you don't see any pelvic floor prolapse, but there is endopelvic fascial weakness or laxity. So this is level 2. If there is a defect in level 2, which is supporting the middle of the vaginal wall and the bladder, what you'll see is like usually the bladder wall is supposed to be like a square. It has to be like equal, but you can see compared to the left posterior wall of the bladder, the right one kind of sags behind. It kind of reaches behind the vaginal wall. So that's called like level 2 or the saddleback appearance, which is seen in level 2 insufficiency. So level 3, which is the more inferior one, which is supporting the perineal membrane and the lower third of the vagina, you will see this is a normal retropubic space. Like this is the pubic symphysis, and you should not see much of retropubic fat. Whereas if the patient has like laxity or weakness of the level 3 endopelvic fascia, this is the pubic symphysis. You will see widening of this retropubic space. That's called the Mustache sign. So this is how you kind of assess if there is endopelvic fascial defect. Coming to the levator ani, which is the pelvic diaphragm. Levator ani is made up of like 3 different muscles. It's a muscle group of puborectalis, pubococcygeus, and iliococcygeus. And the active support is by the levator ani, group of 3 muscles along with the ischio-coccygeus. These are the muscle groups. You can see it's like in an order. This is the red one is the puborectalis muscle, which is the only muscle that we usually see on the MRI. And then this pubococcygeus in green and the iliococcygeus in yellow are usually not seen on the MRI because they are fan-shaped muscles arranged obliquely, and it doesn't align with the plane of the MRI that we do, so they are usually not seen. The only muscle that we see on MRI is the puborectalis. And this on the sagittal view, this is how the muscle appears. It's like reaches from the anterior to the posterior one. So on MRI, this is how you see. So you will see like a thick U-shaped muscle that attaches behind the posterior aspect of the pubic bone and then goes surrounds and covers, attaches to the other side. It usually covers all the 3 openings, the urethral opening, the vaginal opening, and the rectal opening. So that's how it kind of like goes around them. So it is very important to assess the puborectalis muscle, and then thickening or thinning of the muscle can kind of tell us like why there's a prolapse. And I have few case examples to show how it appears. This puborectalis muscle kind of relaxes during defecation and contracts during Kegel maneuver. And this is one of the muscles that they focus on training when they do a pelvic floor physical therapy. So there are different shapes and thicknesses of the puborectalis muscle thing. For example, in this patient, it's like wide U, it can be V-shaped, it can be an hourglass shape, but measurement is usually done. I can show you, I have another slide to show how we measure. So the shapes do not matter, but the thickness of the muscle does matter. And then the third layer is the urogenital diaphragm, which is the anterior triangle. So this one, which has covers the urethra and the vaginal opening, and the posterior triangle covers the anal canal. So levator hiatus width is something we include in our reports. It is technically the anteroposterior diameter is a H line, which we usually make a measurement, and this is the orthogonal plane to the H line. So it's the mediolateral diameter of the pelvic hiatus. So you measure from the inner margin of the levator, this puborectalis muscle, to the inner margin of the other side of the puborectalis. You should not include the muscle by itself because the bulk of the muscle varies in different patients. It can be 1 millimeter and it can be 10 millimeter. So it kind of like causes bias in like our measurement. So you should measure from the inner margin to the inner margin. And then you can see it has to be measured at the widest point. If the widest point, sometimes the rectal gel and patients can have an opening canal that can kind of like make the widening more posteriorly. In that case, you measure at the middle part, but usually it's measured at the most widest part in the patient. And this is how you measure the thickness of the muscle, like just the muscle bulk on either side. Most of the time it's symmetric, but you will see a lot of times it can be asymmetric as well. The asymmetric thinning or the tears can be seen. Exceptions when you don't measure the levator hiatus width is, for example, in this patient, you can see there is multi-compartmental external prolapse, like the bladder is completely outside. This is the pubic symphysis here. I hope you can see my cursor that I'm showing. So this is the pubic symphysis and this is the coccygeal tip, and you can see this is the pelvic floor, and the bladder is completely outside the patient's. There is procedential, uterine procedential. You can see the uterus. This is the endometrial canal. So this is completely outside. Not so much of the posterior compartment, but these are all outside. In this, like technically, like though it looks like the muscle, the puborectalis is kind of completely weak, and it's going to be hard to measure. And always measure the pubic levator hiatus width at the inferior margin. Like I'll go back to the slide. It has to be measured only at the most inferior part of the pubic symphysis, not the level below them. Even though you see something like a contour of a puborectalis, it has to be measured at the inferior margin, not at the top, not in the middle part of the pubic symphysis, but at the most inferior margin. The slice below this should not be showing a pubic symphysis. That's how like you kind of like go there and then measure, because otherwise the measurement will be wrong. Like for example, in here, you see a contour kind of looks like a puborectalis. It is the puborectalis, but it's like, it is not the pubic symphysis. It's like a level even below them. So this is not where you measure. So it's like complete procedure. So you don't measure those in these patients. Quick mention about the physiology of pelvic synergia. There are only two things that happen when patient is trying to evacuate. One, a patient has an increase in the rectal pressure, saying like it triggers the brain to say like, hey, it's time to evacuate, and then it has to be coordinated with relaxation of the external anal sphincter. So this happens if a patient is in synergia. But what happens in patients with dyssynergia, which they kind of like common frequent indication that we get is, they say like patient can have sensation of rectal fullness or like the feeling of I need to evacuate, but they do not have enough strength, anal canal relaxation, so they kind of have like an obstructed defecation, or they can have like inadequate pressure inside the rectum that is not triggering the brain to evacuate, leading to constipation, or they can have a paradoxical contraction. So a combination of either of them can cause pelvic dyssynergia. So I have like a couple of interludes. So as we're shifting from like one topic to another, we saw like why imaging modalities. We looked at what's the pelvic floor anatomy and physiology. And then we're going to move into imaging interpretation now. So obstructed defecation is a very common thing that we kind of like get referred to. What constitutes obstructed defecation is like chronic constipation, like 6 months or more, in patients who fail to evacuate their rectum. It's usually because of paradoxical contraction or the relaxation of the pelvic floor muscles during evacuation. And the diagnosis is usually based on clinical history, the symptoms the patient describes, anorectal manometry, EMGs, and difficography. So it's a combination of things that result in the diagnosis. And when it comes to imaging, what are the things that we look at is like patients can have inadequate opening of the anal canal, because patient will not be able to evacuate when you're doing the evacuation maneuver. They can have an inappropriate anorectal angle, which kind of technically says like the patient is doing a paradoxical contraction during evacuation and when it has to be relaxed. There can be incomplete evacuation of rectal contrast. The patient will be able to evacuate, but like not 100% of the contrast will be evacuated. Despite doing multiple defecation sequences, the patient will only be evacuating 25% of it. Having with all the additional pressure, they can have an anterior rectal seal or rectal intussusception. These are all, not all of them have to be present, but a combination can be present in patients with obstructed defecation. So how do we interpret MR difficography? So usually we start off with the sagittal T2 sequence, and like this is the line diagram to show like we have an anterior compartment, middle compartment, or the apical compartment with the uterus, and then the middle compartment with like peritoneum, and then the posterior compartment, the rectum. So the most common reference line that we use is the pubococcygeal line, which is reaching from the pubic inferior margin of the pubic symphysis to the last coccygeal joint. It's not the tip of the coccyx, but the last coccygeal joint. And the reason I said it's the most common is like there's another reference line that we used in imaging that's called the mid-pubic line, which goes along the pubic bone. And this kind of like, this is how like the line will go. The importance is that kind of closely reflects to the middle compartmental assessment, because if you remember in the POPQ assessment, which the gynecologists do in the clinic, I mentioned about hymen being their reference line. In our assessment with PCL, pubococcygeal line, it is nowhere close to the hymen, but the mid-pubic line will kind of have very similar reference point as the POPQ with the hymen. but we use the pubococcygenic. This is recommended by most imaging literatures to use the pubococcygenic line because it reflects the accuracy. So after we do the reference line, the other one we do is the H line, which is you draw a line from the inferior margin of the pubic symphysis to the posterior anorectal junction. It shouldn't include the muscle mass by itself, but they usually the puborectalis muscle and the posterior rectal wall are closely abutting. It's like a sling, as we said before. So it will be closely abutting. But if you see a thickening of the muscle, don't include the muscle, but the posterior anorectal junction. That's where you draw, and that's the H line, which is technically the anteroposterior diameter of the levator hiatus. And if it's abnormal or elongated, it's usually like 6 centimeter or less. If it is more than 6 centimeter, it kind of reflects relaxation of the hiatus. And then the third line is the M line. It is perpendicular line from the H that joins orthogonally to the PCL. So that's reflects the pelvic floor descent. It's usually less than 2 centimeter. And if it's more than 2 centimeter, we say there is a pelvic floor descent. Not necessarily reflecting the pelvic organ prolapse, but it usually says the pelvic floor by itself is descending, because there are different criteria for organ prolapses. So patients can just have pelvic floor relaxation and descent without having an organ prolapse. We'll go over like how the organ prolapses are graded. So this is the classification criteria, how we say like mild, moderate, or severe. We don't have to like memorize with all our structured templates in radiology reporting. We have like pick lists where we kind of say like we make the measurement and then we pick like, oh, it's 8.5 or 8.2, and then it kind of tells, it puts into the report is moderate, severe, or other things. All that we have to remember is what's the normal value. H line less than 6 centimeter and M line less than 2 centimeter. And then other angle measurement that we use is the anorectal angle. So in a resting phase, the normal angle is about 108 to 127. Sometimes you will get less than that. But all that we care about is how much it changes from the resting on the Kegel maneuver or the evacuation. So it's not a strict number that it has to be 108. If the patient has 105, it's still fine. But all that we care is like how it changes relative to the resting on this evacuation and Valsalva. The way we measure is we draw a line along the posterior wall of the rectum, not through the anal canal, because distension of the rectum with the gel is variable. Patients can have a tubular rectum. Sometimes it will look funnel shaped, very wide at the top and very narrow. So in those, if you're measuring, it's going to be a false number or the angle. So it has to parallel the posterior rectal wall, and the other line is through the anal canal. So that's how we measure the anorectal angle. And then with the stress maneuver, when the patient is trying to squeeze, the pelvic floor goes up. So when the pelvic floor is moving up, the angle becomes more acute. It has to reduce 15 to 20 degrees compared to the resting phase. That's the most important thing. And then when the patient is trying to do Valsalva or the evacuation phase, patient is trying to increase the intra-abdominal pressure, pushing the pelvic floor down to evacuate. So this angle should become more obtuse compared to the resting, and which opens 15 to 20 degrees from the rest. So that's what is important. So just trying to show, I hope it's projecting well. This green line, the anorectal angle in this patient, when somebody measured, they did it through the center of the anal canal, sorry, the rectum, and then the anal canal. This is the wrong method of doing it. It kind of measures 125 degrees, which is wrong. The way to measure is draw a line parallel to the posterior rectal wall and through the anal canal. It's about 88 degrees, and this is the correct method of doing. Though it doesn't come within the reference range of 108 to 127, this is normal for this patient. And what we have to assess is how much it changes with the Kegel and evacuation compared to 88 degrees. The coronal views are kind of like arbitrary. It's more for like assessment when the patient is abnormal. So this is a patient in resting phase. And then when the patient is doing Valsalva, you can see like this is the puborectalis muscle, like on the resting, you can see like this Y-shaped muscle. That's the puborectalis muscle. This is the puborectalis, and it comes down, becomes the external anal sphincter. So this muscle, you kind of see it's kind of inverted here. This patient had a grade 5 rectal prolapse. So you can see how it changes on the coronal for the resting and Valsalva. But other than that, we do not make any measurements on these views. Coming to pelvic compartments, You have the anterior compartment comprises of the bladder and the urethra, and then we assess for cystocele or urethral hypermobility. Apical compartment, the middle compartment is technically all of them. So the apical compartment contains the uterus and the vaginal prolapse, and then the middle compartment comprises of the small bowel, like the enterocele, sigmoidocele, or the peritoneocele. If we are assessing in male patients, this apical compartment doesn't exist, so you will technically measure only the enterocele, sigmoidocele, or peritoneocele. In your reporting template, you can just remove the uterine part because there is no apical compartment. And posterior, it's technically the rectum. So all that we are assessing for is rectal intussusception or the anterior rectocele. So this is how it appears in our MRI. So anterior compartments, middle compartments, and then, apical, middle, and the posterior compartment. So some examples of the anterior compartmental prolapse. So this is a patient at the resting phase, and it's normal for this patient. You can see the bladder is above, the uterus and the vagina are above the pubococcygeal line, and then the rectum is filled with gel. Although the rectum is like an open anal canal, this kind of signifies there is some kind of like anal sphincter abnormality. But in this patient, when the it shouldn't say normal, it should be at the resting phase. In the second image, you can see with the pubococcygeal line in red, the green is like how much of bladder which was above the pubococcygeal line kind of comes down. Though it looks normal on the resting phase, you can see how much of it comes down. And then you can also see other compartments. The rectum is completely outside in this patient, and you can see there is peritoneum coming down, there is sigmoid colon that's coming down. All these are abnormal. But for focusing on this patient for anterior compartment, the bladder has to be at least more than 1 centimeter below the PCL to call it as a bladder descent or the cystocele. Less than 1 centimeter of descent, we do not call them as cystocele or bladder descent. Urethral hypermobility is something that we kind of like comment on it. It's important for the urogynecologist because when the urethra, the urethra is usually kind of like parallel to the pubic symphysis or slightly curved. But when the patients are having bladder descent, it kind of buckles and curves under the pubic symphysis. That's the imaging correlate of a patient with stress incontinence. And seeing this and mentioning it, it helps them to assess if the patient is a surgical candidate or not to fix this stress incontinence. So this is how we kind of like assess for urethral hypermobility. And then coming to the apical compartments, this is a patient, you can see the uterus uterus and vagina is above the PCL, but when the patient is kind of doing the evacuation maneuver, the bladder comes down and the vagina also comes down. So the reference points are, if a patient is having a uterus, you measure at the antero-inferior aspect of the cervix as a reference point to measure how much of vaginal descent is present. But if the patient had a hysterectomy, you measure at the posterior vaginal apex, or the vaginal vault. That's the reference point. So if it's cervix is the reference point for when the patient has uterus, and the posterior vaginal vault is for patients with hysterectomy. And the same patient, you can see as the patient proceeds to perform more pressure, you can see the bladder is completely below the PCL. You can see the uterine fundus is below the PCL, and there's peritoneocele, there's small bowel loops coming down, there's rectum is completely outside. You can see it's completely inverted. For a uterus to come down, the uterine, not any part of the uterus should be below PCL, the entire uterine fundus has to be below. Though we think it's like highly unlikely, but you can see in this patient, the uterine fundus is below them. So if let's say like this part of like middle third of the uterus is below the PCL, you still call them as vaginal descent, but not uterine descent. The fundus has to be below. Middle compartments, as I said, if it's enterocele containing small bowel loops, peritoneocele containing fat, and sigmoidocele containing the sigmoid colon. And in this, you can see we don't measure the enterocele or sigmoidocele. We only say whether it's present or absent. Whereas for peritoneocele, we say what's the lowest point of the peritoneal fat that's below the PCL. We kind of make that mention. So you can just see this is the fat coming down, and you also have small bowel loops coming below. And this is like a GIF that shows like how much of widening happens when the patient is evacuating. And then you can see the bladder is completely inverted. So much of fat comes down. There's small bowel loops and also like sigmoid coming down as well. So this is another example, the same example showing that. This is another example to show varying degrees of peritoneal seal. In this patient, you can see very small amount of fat is coming here, whereas in this patient, a lot of fat is coming down below, and also the sigmoid is coming down. You can see these divertical as well. Posterior compartment is different because we assess them for rectal intussusception, which is intussusception of the mucosa within the rectum, and the rectal prolapse, which is posterior. And then there's an entity called the anterior rectal seal, where the anterior wall kind of prolapses outside. That's important because clinically these patients present with incomplete evacuation symptoms because they'll have a bowel movement, but since there is trapped, because if this rectal wall is weak, it doesn't contract, and if there is stool contents going into this anterior outpouching, this does not evacuate, and patient will have a bowel movement and come back and say, like, I feel like I haven't like completely evacuated, and they keep having frequent return to the bathroom. So it causes more of like social life restriction for these patients. So this is actually a much more simpler surgery for the surgeons to fix. I'll let Dr. Antonio talk about it more because he's expert. But what I've heard from the surgeons, that's more simpler surgery. If that's the only thing present in the patient, it's much more easier to fix. And in this patient, you can see the way we measure is you draw a line through the anterior wall of the rectum, not the posterior, but anterior wall of the rectum. And whatever anterior rectal wall that's prolapsing is measured. And we kind of grade them as well, like depending on how many centimeters it is anterior to the anal canal wall is the anterior rectal seal. And the other thing we comment on in our reports is, does it, like patients can have anterior rectal seal, but by the end of evacuation, sometimes entire contrast will get evacuated. That's better than still having retained contents, which kind of correlates to having incomplete evacuation. And you can see like this is black, is the air within the stool contents. And sometimes like we'll see like the gel gets expelled, but like the air is still retained. We still count them as incomplete evacuation because air or gel doesn't matter. Both has to be evacuated. So we call them as retained contents in the anterior rectal seal even if only air is present, but the gel is evacuated. And this patient, you can see there's bladder, peritoneum, and other things, and also like rectal prolapse, the grade 5 prolapse. And this is very important because MR difficography is the only one that can assess this rectal intussusception. The clinicians can see if there is a grade 5 prolapse, but the grades 1 to 4, which is internal rectal prolapse, intussusception, can be assessed only on MR difficography. The grading is such that, like, you can see the first 4, this is an Oxford grading system, which we kind of use in our reports. The first 4, you can see those are all intrarectal or intraanal. That's not external. Grade 5 is the only one that's external. That's the anal, the rectum is outside of the anal canal. So this is grade 1, where the rectal mucosa comes up to the level of the anterior rectal seal, and then it's into the rectal seal, but not into the anal canal. Third is up to the anal canal. 4 is through the anal canal, but not exterior, and 5 is outside the anal canal. So that's how we grade them. Like few examples. So this is how it shows, like the rectal mucosa is kind of intussuscepting through the anal canal, but it's not outside, but it's through the anal canal. That's grade 4 intussusception. And then this is another example of showing like how much there'll be an anterior rectal seal, but then like the gel expels, but then you still have some air that's kind of retained. We still call them as retained contents. So these are the different compartmental prolapses that we kind of went over. So we looked at the measurements. So H line, you measure them on all the 3 phases, like resting, Kegel, dynamic. M line also is measured in all the 3 maneuvers. The levator hiatus width and puborectalis is measured only on the axial T2 sequences in the resting phase. And then anterior compartment, as we went over the different compartment, like how we measure them. Just kind of transitioning to the next one, we're going to go into the case review series. So this is a 66-year-old female with complaints of constipation and also incontinence. So you can see like there is both like constipation and also has incontinence. Anorectal manometry was performed, and they said abnormal rectal propulsion versus a poor effort. So they did not know which one is the cause, so they sent them for MR difficography. And you can see on the axial view, you can see there's so much of widening. So the levator hiatus width is 7.2. The normal is 4.5 centimeter or less. So you can see there's widening of the levator hiatus width. You can see the muscle is super thin anteriorly. There's some amount of muscle bulk posterior, but anteriorly it is like super thick, so thin. You can't even see it on the right side. And then when the patient is doing, this is resting phase, and compared to the resting, when the patient is doing a defecation maneuver, you can see how much of bladder is below the pubococcygeal line. And then there's also some amount of peritoneal seal. And like the vaginal descent also is present. You can see a patient had a hysterectomy, but you can see the vagina here, and then this is below the vaginal PCL. And patient had, you can see this is the mucosa that's buckling into the level of the anterior, small anterior rectal seal, but then it's buckling up to the level. So that's the grade 1 intussusception. Case 2, 68-year-old female with complaints of pelvic organ prolapse. Patient had history of anal carcinoma. Patient had a post-radiation therapy and rectal prolapse for 5 years. Surgical planning, this is how it was. Patient, they couldn't perform an anorectal manometry because patient had a prolapse. So you can see this is the resting phase. The interesting part is the technologists call us and say like, hey, like the rectum is completely outside. How am I supposed to push it in and like put the gel? So these are like the tailored maneuvers that we perform. We said like, we're not touching the rectum. We're not pushing it anywhere into the cavity. That is not our job. We said like, this is mainly for assessing because we were going to like fix this. Patient had like radiation changes and all that. It is causing problems. So the GI surgeon was going to fix the problem. But they also wanted to know, is there an anterior or middle compartmental prolapse as well? Because in that case, they're going to bring urogynecology and gynecology into the OR so they can do a multi-surgeon like work on it so the patient doesn't come back for a second surgery, which is the right way to go. So we did not do rectal gel in this patient. That is only for assessing if there is a prolapse. In a patient with grade 5, you don't do anything. We don't put any gel. It's only, we do the maneuvers just to assess how much the other compartmental prolapses are present. And this, you can see there's so much of thinning, uniform thinning of the puborectalis muscle, and there's widening of the levator hiatus width. And then this is resting phase. The bladder is about 1.2 centimeter below the pubococcygeal line. And you can see, obviously, there's peritoneal seal, there's small bowel loops coming in. Rectum is not even seen because it is completely outside. But with the defecation, you can see patient's bladder was coming down more, which the other compartments were seen with the resting, but bladder prolapse was seen much better with the defecation. Though by measurements on the resting phase is grade 1 bladder descent, when they're doing a defecation of the stress maneuver, you can see it becomes grade 2. So this is a thing to remember, like don't put gel in patients with grade 5 prolapse. It's more for the other compartmental prolapse coexisting in this patient. This is a 27-year-old female with complaining of fecal urgency throughout the day, but is unable to evacuate. But she has some mucus leakage. She has tried all the medical maneuvers like conservative management, and nothing worked. The anorectal manometry showed equivocal dysynergic defecation pattern, suggesting a pelvic floor dysfunction. So they send this patient to us, and you can see when the patient is like the kind of like at rest, you can see there is no prolapse or descent that we see, and then the patient is kind of pushing further. You can see the bladder comes much below. There is vagina. This is the vaginal canal, so you can see how much is below the PCL, and then also has rectal interception. I'm going to show you here. So this is static images. So in this patient, interestingly, you can see the levator hiatus width is still less. But this patient is having, because of the chronic constipation and pressure, she's having laxity of the pelvic floor. But the muscle is like at rest is fine. So you can see the patient is having grade 2 bladder descent. This is the anteroinferior part of the cervix. That's the vaginal descent. Uterus fundus is still above. And then you can see this is the rectal mucosa that's prolapsing into the anal canal, proximal part of the anal canal, but not through it. So it's grade 3 rectal intussusception. So this is how it appears. This is an interesting case that I love to show everyone. This was a 44-year-old female with history of complicated vaginal delivery. She had a vacuum-assisted delivery, a prolonged vacuum-assisted delivery. And then she presented 4 months after her delivery that she was feeling a lump in her left perineum. The clinician felt it. It was a little softer, but it was definitely a lump. So they did not do anorectal manometry, but they sent them directly to RMR. And you can see, like, if you notice here, you look at the bladder, and then when the patient is doing much maneuver, like the bladder is disappearing here, and then you start seeing a bulge corresponding to what the clinical complaints were. And this is because the patient had a tear of a left puborectalis sling during the complicated vacuum-assisted delivery. So there's a tear which was causing the bladder to kind of bulge through the left side defect. So you can see on the coronal image, you can see this is the bladder that's kind of like coming out through the defect into the left perineum. So this patient went and had a sling procedure to fix the defect, and she was better after. So that's how, like, paying attention to how much the patient is pushing down is very important. This is the same patient. Okay. This is a patient. You can see these images here. There is, when the patient is kind of pushing down, you can see how much of the rectum is kind of intercepting coming up to the anterior rectal seal. So this patient has bladder descent, and it has like the uterine fundus in this patient. You can see this is the fundus of the uterus that's kind of below the pubococcygeal line, has like some amount of small bowel loops coming down, and then anterior rectal seal and rectal interception. Another case to show, in this patient, the patient had a hysterectomy. So that is an option. We do not do vaginal gel on routine, but if the clinicians have a question about vaginal gel in these patients with the hysterectomy, the vaginal wall is completely collapsed, it's going to be very hard for us to see. So we do sometimes have an option of putting gel into the vaginal canal. So it kind of like tells us where the vaginal wall apex is. So that's what was done in this patient. We have a rectal gel. You can see the vaginal apex. This patient has a bladder descent. Vaginal apex is below the PCL, has some peritoneal, small amount of peritoneal seal, and then anterior rectal seal. You can see that this gel never gets emptied throughout the evacuation maneuver. So that's anterior rectal seal not evacuating. So this is a patient on the resting phase. You can see this vaginal. We do put in a vaginal gel, but most of the patients have a closed anal canal just because the sphincter has to be intact. So on the resting phase, if you're seeing after the catheter is removed, if the patient has gel in the anal canal that's widely patent, then you know there is some sphincter dysfunction. In this patient, you can see like when the patient is evacuating initially, there is some amount of rectal interception. You can see that is like at least grade 3, but then we do this 90-second evacuation maneuver, telling the patient keep pushing as much as you can, because we want to replicate what happens in their bathrooms like on a day-to-day basis. And you can see if we stopped it earlier, we would have said like it's grade 3 rectal interception. But when we kind of like proceeded, and when the patient does a maximum amount of pressure, you can see this patient has a grade 5 rectal prolapse. Apart from you can see this rectum completely comes outside. So this grade 5 along with other bladder 1. So same thing that I'm showing in a bigger image. Quality assessments, I just want to mention it here. Sometimes you will see patients find it uncomfortable, though they're covered with blankets, coils, and they know nobody's actually watching them evacuate. It's more of a social pressure. Almost all of them are adult patients, so they know somebody's watching them as images. So they'll say like, yeah, I'm doing it, but like there'll be no movement of the rectum. They'll say like, yeah, I'm pushing. So the way to assess if the patient is actually performing the procedure and not able to evacuate, which is pelvic dyssynergy or obstructed defecation, or there is more social causes that the patient is not doing adequately, is to look at the anterior abdominal wall. If the patient, when they're doing a Valsalva or evacuation, if the anterior abdominal wall moves anteriorly, which means they're increasing the intra-abdominal pressure, you know the patient is making the effort but not able to evacuate. That's very important for us to assess. A lot of times we have to say like, hey, we understand, but on images we can see that you're not making the adequate effort, and then the patient gets better after that. So always look for the anterior abdominal wall to say if the patient is doing it or not. The same way for Kegel, the abdominal wall has to go like scaphoid. It has to be pushed in because of they're trying to do a Kegel maneuver. Case 8. So this is a patient. You can see like the elevator height is with is fine. This patient is trying. You can see the anterior abdominal wall is moving outside, but then like no gel comes outside. Literally no gel. Patient is really trying. You can see that rectum is moving, anterior abdominal wall is moving, but usually we try to do 3 consecutive maneuvers. If the patient evacuates the entire gel in one, we stop. But if the patient doesn't empty completely, we at least try 3 times to do the evacuation maneuver. You can see like there's nothing coming out. So this is no emptying with multiple attempts. It's obstructed defecation or pelvic dyssynergia. The other thing we do in a clinical practice for practical aspect is if the patient is not able to do it, we say like we finish the exam, we take the patient out and we ask them to go to the bathroom and say like, hey, try evacuating the gel and come back and tell the technologist whether you were able to like expel the contrast or not, rectal gel or not. So if the patient says, yeah, I was able to evacuate in the bathroom, it means it's more social causes, that the patient had some inhibition, everybody watching them. And then we kind of make a note in our impression saying like, there was no evacuation of the contrast during examination. However, patient was able to pass in the bathroom, which could represent more of a social cause, because if the patient tells they couldn't evacuate even in the bathroom, then it's like a true obstructed defecation, which makes a big impact on the clinical management, because that kind of confirms the clinician's suspicion. So it's very important for them to know that discrimination. Two more cases. I think I'm on like at the time, so I'm going to quickly go over these cases. I'm almost there. This is a unique example. This patient she's a 19-year-old, very young patient. She has constipation straining, and she also had some prolapse. So in this patient, usually all that we see is anterior rectal seal. This patient had like small amount of anterior rectal seal, has retained contrast. The important thing that we saw is the posterior rectal wall. Usually this never buckles. Usually this is the anterior rectal wall, which is lax and prolapses, but the posterior rectal wall, it was kind of buckling inside. This is a posterior puborectalis contract syndrome, or the paradoxical contraction of the posterior. This has to be relaxing along with the anterior wall to evacuate the gel. Instead, when the patient is trying to evacuate, this is kind of buckling, and so there's a paradoxical contraction. So this is also something that the clinician would appreciate if we tell them. So it's important for them to manage accordingly. They can go in for neurobiological training of how to like evacuate and stuff like that. The last case, this is a 58-year-old female presented with constipation and also had like recent episodes of fecal incontinence. So she had constipation and also incontinence. No trauma, no surgery. So we were looking at it. The rest of the examination was all fine. She didn't have prolapse. She didn't have laxity, nothing. The only thing that we could find was this anal sphincter. You can see there's a small little defect. It should be a round, as we all see in every anal sphincter, it has to be a round muscle. But instead, we saw a small defect. So probably because of the chronic constipation, she tore the anal sphincter, and that's the reason she started having fecal incontinence as well. So even this information is important, because it's very hard for the clinician to examine like the anal sphincter like fibers. If it's like very thin tear, MRI is much better for them to like confirm the findings, which kind of explains the patient's symptoms as well. So pay attention to all the features, especially the clinical indication. So management, usually pelvic floor dyssynergia is managed by like biofeedback mechanism, like training them with a special machine and sensor probes. They can do botulinum toxin injections to relax the muscles, nutrition therapy, pelvic floor exercises, physical therapy to strengthen the puborectalis or the levator ani muscles. They can give pain management if the patient has pain, pelvic pain because of these dyssynergia. They can do some amount of low dose muscle relaxants. And of course, when all of these fail, surgery is the final thing. So quick recap. I just wanted to show this is the Society of Abdominal Radiology reporting template. It's on the website. If people are interested, like you can kind of download the template and make it into yours. It's kind of very easy. It's very quick to report because it all has these structure templates and pick lists. You just have to make those measurements and then just kind of like plug in your answers into the impression. So key takeaways: pelvic floor dysfunction can be just dyssynergia or it can be organ prolapses. Rule of three. This is my rule of three, like I just made it up. To remember, I tell my residents, like remember what measurements you have to do. Like you have to measure the H line, M line, and anorectal angle in 3 maneuvers. Measure all of these in like resting, Kegel, and evacuation maneuvers, and in all 3 compartments, the anterior, middle, and posterior compartmental prolapses. And thank you for the opportunity. And these are like some suggested readings. We have a number of articles in literature, but these 3 are like some suggested like great reads. And if people are trying to understand or like reference, these are 3 good articles. And I'll stop here. And I'm open for any questions if anybody has one.
Thank you, Doctor, for this varied lecture, simplifying this complex topic. Now we will give a chance to Dr. Antonio and Dr. Nitrine to their input and discussion from, if they have discussion from surgical aspect of this topic, pelvic floor imaging.
Sure.
Dr. Antonio?
Yes, can you hear me?
Yes,
Can you
doctor.
hear me?
Nice and
Yes, Dr. Antonio. Yes,
First,
yes.
first of all, congratulations, Dr. Jawad. That was an excellent presentation.
Thank
And
you.
I want to make a few comments, just picturing what we have here in the UAE, what's going on. I'm sure Dr. Nasreen also will give her input. This kind of meetings are very important because there is little awareness about functional diseases. It's not only functional, it's a combination of sometimes of anatomical abnormality and functional problems. Let's say that we don't have MRI defecography in all hospitals. We are very lucky in Bourjil to have the MRI defecography and excellent radiologist reporting. But I work in both Abu Dhabi and Dubai in 7 hospitals. And I tell you, only in 2 hospitals actually we have MRI defecography, although the others are actually quite tertiary referral centers. Regarding the treatment, we have biofeedback nurses. There are only around 12 in the whole UAE. It's very difficult to find a biofeedback nurse, to the point that some of my patients go back to India, have their own sessions of biofeedback and come back, because most of the time they have to go privately to do it, or they are not covered in the particular hospital that offers. I mean, Bourjil Medical City, Bourjil Group, we are very, very lucky because we have excellent radiologists and we have also a biofeedback nurse, Hina, that she's excellent. And actually, I will take the opportunity, we have an ongoing trial of pelvic floor dysfunction, which is the first in the world, which we combine the biofeedback with relaxation techniques that, how dysfunctional disease actually is more about the body and mind relationship. But also, the important thing is training more radiologists to read them. There are not many radiologists trained to read them, and many units don't want to do them because they say it takes time. We have other MRIs which are important to do, but they are missing. Even if we consider that most hospitals are private, we are not considering actually the financial gains. I mean, I'm talking about UAE, for example, Abu Dhabi. Sessions of biofeedback go to 500 per session. So considering 4 to 6 sessions, that is a lot of money. Also MRI defecography. So awareness amongst gastroenterologists, this is so important. And there are not many colorectal surgeons in UAE that actually have a subspecialty in pelvic floor. And I see a lot of patients coming for pelvic pain, for example, and they've gone through hemorrhoidectomy, fissurectomy. What they have is a pelvic floor spasm, or they've gone years and years with laxatives. And what they have is a non-relaxing puborectalis that actually an MRI defecography would actually have shown. So gastroenterology, we need to be really pushing the gastroenterology to refer patient. There is a lack of a referral, considering that 20% of chronic constipation is related to outlet obstruction. And I think here, even the guidelines are biased. The American guidelines say that if a patient has got problems with chronic constipation, first try laxatives. But I've seen a lot of people with laxative. Of course, they improve, but the source may be spasm or maybe a rectal invagination that has been missed. That is not so. So the patient will improve, but will never get better. Will stay years and years on laxatives. So it is important, even as surgeon, to examine this patient very well, but also the history is of pivotal importance. For example, it's not just a question of, do you struggle on opening your bowels? Do you is your stool hard? There are some questions that actually sometimes make us lead us to a diagnosis. For example, if you ask the patient, when you sit on the toilet and you strain, do you have to do particular movements? And some people, they will tell you they do very odd movements with their body. They crunch up, they stand, because what they are trying to do is to relax the puborectalis that sometimes gets into spasm. How do you recognize that during the examination? Well, with your finger, you see exactly, there is usually pain, usually on the left side of the puborectalis sling, and you see this hardness, this tension of the muscle. The problem on clinical examination, we don't have a dynamic assessment because we can say, yes, the muscle is into spasm. And rectal manometry does not assess much the puborectalis, is more about, and that is why it's important the MRI, the echography. Although that will be a question for Dr. Jauer. What about the sitting one? Because, you know, we examine the patient in the left lateral position, and it's very difficult for them to push in the left lateral. When I was working in UK, I was leading a pelvic floor unit. We had the commode there. The patient would sit and would push. But this is awkward, especially, you know, we have patients that, you know, because of also a cultural, they are very discreet, they're shy. So it's very difficult in the clinic to make them sit on the commode and expel the balloon. But also, that's a question for you. If the sitting MRI is actually may improve that, although I know that the supine MRI has got better delineation of anatomy than a sitting one, but the sitting one may give us more functional, especially in obstructed defecation findings. So one question for you would be, you know, should we do both of them ideally, or what would be a compromise when, of course, open MRI will be more and more available? And then another question for you would be, where do you get most of your patients? They come from gastroenterologists, they come from physical therapy, they come from surgeons. Another thing that I wanted to point out is that it's impossible on clinical examination to have some details that we have for MRI echography. The question is, even when you do an anoscopy and you ask the patient to push, you may see like an internal rectal prolapse going almost inside your anioscope. But you can never diagnose a rectal invagination and telescoping of the rectum. I saw a patient 2 weeks ago. She had these problems, laxatives for many, many years. She was actually depressed and did an MRI echography, and there was a telescoping of the upper rectum. And that was the cause. And the rectopexy actually resolved the issue. So again, functional and anatomical. We have to rely on symptoms. If a patient comes with chronic constipation, even with pain, we just not have to focus on the constipation and the pain. We assess also, do you have problems while you urinate? Do you have problems during sex? Do you have dyspareunia? I mean, the pelvic floor, that's why importance of the uro, gyne, colorectal, and all three together, especially in UAE, for example. You know, in other countries, I would examine also the vagina, the uterus. It's not something that I do here. So I rely a lot on what the gynae tell me, and of course on imaging, such as like MRI and echography. So what I'm saying is we need more awareness, more knowledge about the problem. It's not just hemorrhoids, it's not just fissure, it's not just a slow bowel. Well, there could be a combination of slow transit, normal transit with outlet obstruction. So in a system where we are, where insurance covers it, and we're not based only on cost effectiveness, as most of the guidelines are. For example, the patient comes to me, I do everything over him. Also because, for example, in Abu Dhabi, some insurances, they don't require approval for examination. So a patient comes to me with anal pain, with chronic obstruction, with chronic constipation. I do detailed history, examination, rectal manometry, rectal sensation. If I feel that there is a problem, I will send it to MRI echography, and then to physiotherapy, pelvic rehabilitation. Most of the physiotherapists here are actually not the real biofeedback ones. And everybody thinks that I send it to physiotherapy. It's not like that. They need to send it to biofeedback. It's not a question of strengthening the muscle. Actually, sometimes you don't have to strengthen the muscle. You have to relax them. So you need to rehabilitate, to reestablish that coordination that has been lost. And one thing that we don't have to correct anatomy. We have to solve symptoms. How many times we see a big cystocele with no symptoms, or you know, we see a big rectal prolapse plus the cystocele, but the patient has got only symptoms from the rectal prolapse. So I deal with the rectal prolapse. I leave the cystocele in place. So this importance of knowledge, awareness of actually, once we have awareness, we will have more people who do MRI defecography. We will have more biofeedback nurses. We will not have the 20% of chronic constipation that I calculate is about 300,000 people in only Abu Dhabi walking around with laxatives while they have a pelvic floor dysfunction. So we really need, and this, I love these meetings, and I myself have been trying to teach around, but I'm struggling to get proper referrals, to get people to sort of think about the functional of it, even the anatomical abnormalities they cannot see clinically. They only can see certain investigations such as MRI defecography. Anyway, I'll cut it short, and the two questions for Dr. Jawar are, one, what about open MRI or sitting MRI? And where do you get most of your referrals?
Thank you for all that insight. I really appreciate, like, I love to learn from the clinicians because we cater to the clinicians, and knowing what you expect makes our reports better. So I totally agree with you. Coming to the MRI part, the open MRI, like, we do not do in our institution, and I don't think in the US nobody does any open MRI. But I know, like, Switzerland, there was like one of the ISMR meetings, we had a research study. They had a very low Tesla, it was 0.35 Tesla. Open MRI in a standing position that they perform for MR defecography, but that's more research, just research. They were doing like a standing one. They said like the results were comparable, though they have very low resolution compared to our 1.5 or 3 Tesla magnets. There was much more lower resolution, but they said they had comparable results with ours, but not superior to them, because they had a comparison of like regular MRI in supine versus another. So to have an open MRI in a standing position, all the open MRIs in the US at least they are still supine, not upright ones. So having an upright one has very specific indication, and most of the institutions, for cost effectiveness and like for, obviously it's all about money, just for this investigation is going to be hard unless like the institution is invested in like, oh yeah, I just want to do this. That's the only drawback. And coming referrals, we are almost 95% of our referrals is from like GI surgeons. Very rarely from other surgeons like Urogyne. Very rarely they send, because if they're like, oh, somebody else said like the patient has multi-compartment prolapse, like we want to see like if you want to do surgery, but most of them are from GI surgeon. I'm trying, like for many years I've been trying to like talk to urogynecology and gynecology, like, hey, it'll make more sense like if you do, like, even though we say there is middle compartment prolapse, the gynecologists still rely on their POPQ score for the management. If we say it's grade 2, they say grade 1, they banish based on their assessments. So it's their clinical assessment. So there's like literally like no one refers just for middle compartmental prolapse or anterior. And anterior urogynecology, they prefer doing their translabial ultrasound in offices because they kind of like they rely on their assessments. So it's a big fight. Slowly they're coming in. I've like in my prior institution that I worked, I volunteered myself my own personal time, and I said like, hey, I will come and like discuss when you're doing a pelvic floor clinic, I will come and like interpret all the images again, and we'll review all the images before you go into the patient's room. So that kind of helped a little bit in my previous institution. In the current institution, there's been a flux of like, this pelvic floor group is like moving parts, like, you know, they kind of like move from one institution. If the group leaves, then it's hard. So our recent group left, so we only have the GI surgeon who's like working with me. So I'm trying to increase the referral, but I agree there should be more awareness to this problem, which will kind of like significantly improve. I trained at Stanford. So Stanford has a very big multidisciplinary conference that happens every month. So they're like literally 10 to 12 specialists, like gastroenterologists, urogyne, gyne, like they also have a neuro gastrobiologist, which I didn't even know they existed. So those kind of specialists come in, physical therapists, everyone, geneticists, all those people come and sit and discuss like the complex cases, which is not resolving with medical therapy. Do we need surgery? So it used to be like a very dynamic, involved program. So I think that kind of like really involves, like, as long as a surgeon or like the clinical team is involved, if there's any radiologist, I think fostering that relationship will kind of like improve a lot. And I agree, like radiologists kind of resist it, because I think if an abdominal radiologist, we don't do complex measurements like MSK, like these angles and measurements. So when they first train, like my residents and fellows, even including myself, when I first trained in MR defecography, I was kind of very nervous. It took me hours to like go through the papers, learn how to make measurements. But then now that I know how to do the measurements, I usually pick up the study first, because it literally takes me 5 minutes, like literally 5 minutes. Once I know where the measurements are, it's just about getting accustomed to like how to make the measurement. But that's the easiest report to do, like report. And I've seen like people always like once they get past that learning curve, they always like jump on the study when it's on the list because they love to do these because they're very easy, very good. And I totally agree with the clinical indication that we have to look into. Most of the time, like, for insurance purposes, the indication that they mention is constipation or pelvic dyssynergia, and that's it. Like, for example, the last case that I showed, patient had constipation and fecal incontinence. Constipation, but I had like, it was a completely normal exam. And I was like, I always try to dig into the chart, and I saw like there's fecal incontinence, and that made me go back and look more carefully. And I saw there was a tear in our anal sphincter. It makes a big difference. I show these cases because clinical history is very, very important to us because we kind of find more things. And if there is pertinent negative, I assume like, okay, this is what the clinician is looking for. And I give that pertinent negative as well, saying like, hey, this is not there in this patient. So it makes meaningful interpretation for them, so they can choose an option B for the management rather than option A, because option A is not necessary for this patient.
Right.
Yeah. Any other questions?
If Dr. Nisreen is still with us, and she had any input or discussion concerning the surgical aspect, Dr. Nisreen with us?
I think Dr. Nisreen is not there because of her OPD is still going on. She just
Okay.
messaged me.
Our colleague, if any question or discussion from their side?
Dr. Anu Gayatri, I have a few questions for you.
Sure.
Yeah, just wanted to know what percentage of pediatric population you're getting for the imaging part.
We usually have like one or two in a year. That's all. Like, because very, very few patients have like, those are usually kids who have like chronic constipation not improving. Those are the ones that they want to evaluate. If the patient is like chronic constipation straining, not necessarily for organ prolapse, but the clinician wants to check if there is consequences or like from the chronic constipation. So those are the ones that we come for. Or very rarely, like I think I've seen only one, which as a childhood malignancy, they had a pelvic surgery, like any kind of pelvic tumor, they had a surgery, and then they have these kind of like defecation problems. They kind of want to assess if any of that surgery affected their pelvic floor. Only one so far, but mostly it's like chronic constipated kids.
Thank you.
Very, very small population. And that those kids are actually, sometimes it's harder. It takes a longer time to train them because it's hard for them to understand the maneuvers. But when they understand, it's like really good. And on those kids are usually in the teenagers, not less than that.
So in continuation of this comment, I have a question related to patients, those who are like elderly patients, patient a bit of anxious mindset, and if your study is incomplete, so how you are interpreting such studies?
If the incomplete ones will be when they never evacuate the gel. So we try to do like 3 maneuvers. We try, by the time 2, nothing happens, we kind of like pause and tell the technology is usually kind of train or not, more than training, like trying to like coalesce with the patient, like, hey, like, this exam is very, very important. Your clinician will be able to make any judgment only based on the results. And we understand it's not a very comfortable exam, but like if you can cooperate, if you can try to relax and then like relax your anal sphincter, like, that will help with the management. Sometimes patients do understand because, they're paying for the procedure, and if it's incomplete, there's no points, like their management, everything affects. So once we tell that, a lot of patients, like we say, like, take nice deep breaths, like calm down, tell us when you're ready, then we'll do, like, usually not too long. So they also want to get out of the scan. So they will be like, okay, calm down, let me try again. And sometimes it does work, sometimes it doesn't still work. So those are patients we say, like, hey, go to the bathroom after the procedure, and then like say, come back and let me know if you're able to evacuate the gel. And then that definitely goes into our report saying like patient was able to evacuate the gel in the bathroom after the procedure, which kind of signifies, correlates more to a social fact rather than a obstructed defecation. So if the patient still doesn't evacuate in the bathroom, then we put it in saying like, this is more suggestive of an obstructed defecation or pelvic dyssynergia.
In such cases, are you using ultrasound as a modality to assess? Is there any additional advantage?
Ultrasound still doesn't do a stress maneuver. They can try to like strain a little bit, but they cannot do an ultrasound when they're defecating. Even if it's a rectal gel, it's more uncomfortable for the patient when somebody's like expelling the gel and doing an ultrasound. So ultrasound never works in those kind of patients for sure. Because when they are like, when patient is all covered up, if they can't evacuate, they never kind of push when when somebody's actually having a probe in their perineum. So it doesn't work in those patients.
Okay.
Maxine?
As
Yes,
you
Dr.
all,
Ahmed. Yes.
he
Go on,
was,
Dr. Ahmed.
sorry,
Sorry?
Dr. Yasir, you wanted to mention something?
No, go on, Dr. Ahmed. Complete, please.
Yeah, thank you. You're practicing in US. Are there any artificial intelligence solutions for interpretation of such images you are using in current practice?
No, not yet. I think it's going to be very difficult because it's very arbitrary. Like from one patient to another, things change, like the anatomy changes, and the way it's kind of like the resolution of the images, like with the cine images, is still like single shot cine sequences. The resolution is much less than the traditional T2 in a resting phase. So I doubt if it for training those AI, like we need like millions of data to kind of say like, okay, this is how it has to look to kind of have an interpretation. I don't know if we have that amount of data from like multiple institutions to be pulled in to like, train those AI. Maybe anterior and middle compartment might be able to do, but definitely the posterior compartment, the rectal interception is very, very arbitrary. Like, there's like intra-reader like variability too. If I'm like really assessing the next time, I'm like, is it 2 or 3? Like even myself, like I try to compare myself, and sometimes like, maybe it's like 2. Then I say like, oh, I said as 3. So it's a lot of variability even for us. So it's going to be hard, especially the posterior compartment. Anterior and middle, maybe yes, because if it's a larger grade, AI might be able to do a measurement, but nothing yet.
Thank you, Dr. Anu Gayatri.
I think Dr.
Maxine?
Yeah.
Dr. Maxine?
Yeah, thank you, Dr. Anu Gayatri, for this wonderful lecture. I just had
Thank
one question. Can we have a rectal descent without having rectal intersusception or rectocele, probably anterior or lateral?
Yeah, we can. We don't say it as rectal descent. We call it as pelvic floor descent because when we say rectal descent, people try to assume it's an anterior rectocele or intersusception. But pelvic floor descent, yes, they can have pelvic floor descent without any of the organ prolapses just because of the laxity. Only if they have those criteria for like bladder base below the PCL or vaginal apex, all those criteria is the one that makes it into an organ prolapse. They can have just the laxity of the pelvic floor, which is kind of precursor of having an organ prolapse later. That they can be at that stage still.
So just in continuity for that, I mean, what criteria do you use? For the anterior compartment, you use more than 1 centimeter as grade 1. For the middle as well, I think it is more than 1 centimeter.
Yes.
And for
Yeah.
the posterior, how much it should be?
Posterior, it's more like it's just rectal intersusception, how much of the rectal mucosa intersuscepts to the level of the anterior rectocele or into the anal canal, that 5 grades. And anterior rectocele from the anal canal anterior margin, it's more than 1 centimeter.
Okay, thank you.
Yeah, no worries.
Any more questions from our colleague? Sorry, Dr. Ahmed.
Yeah, Dr. Yasir, please go on.
Any more questions from our colleague? We can close the webinar now.
Yes. Yes, Dr. Yasir.
Thank you, Dr. Anu. Thank you, Dr. Anu. Thank you, Dr. Antonio, for this participation and this valid lecture. Thank you for our colleague for joining us in this. And this is the first webinar in this year. As Dr. Amol mentioned earlier, this is starting to be under CORAD of Virgil Holding. And this year we'll start to concentrate on international speakers and the complex topic which we have little deficiency in practicing it according to the number and according to the practice in our unit and our locality. Again, thank you all and see you in the next month for the second webinar, inshallah.
Thank you.